Okay, thank you, Quentin. Well, welcome everybody. Yad eshe karin yazi yunisha. Kitachini nishla tanasani bashashin kiani dashache tachini dashanella. So I just introduced myself in my Navajo language. I am Danette. I'm from Kayenta, Arizona. If we have any K-Towners here or people from the Navajo Nation, but I am going to be here today with you all for this final session of our suicide prevention convening. And I am the prevention coordinator at the Phoenix Indian Center. So I wanted to welcome you all into the space, into this session that is hosted by the Phoenix Indian Center and the Urban Indian Coalition of Arizona. So if you didn't know already, this year is the Phoenix Indian Center's 75th anniversary. So we've been serving the urban American Indian community for 75 years now, and you can see it in all of our backgrounds. We're celebrating all year long, so we have signature events that we're going to be rolling out. So keep an eye out. A lot of them are all community based, so they're free to the community and open for everyone to join. But we have been and continue to offer workforce services, prevention services, youth development, language and culture workshops, and so much more. So if you're interested in learning about, more about what we do and the services that we offer, please follow us on social media and check out our website. Amanda is going to put all of that information into the chat box, and you can take a look there. But the suicide prevention convening is held each year and is typically in person. However, of course, with the pandemic and COVID, we have moved to a virtual platform. And split this session into 3 sessions. So if you've been here since January, you know that today is the final session, but it's really what this event is a gathering of community members and local organizers to come together and help establish suicide safer communities for our urban American Indian families. So we've covered different topics. This year we've had humor healing with comedian James June. We also had a parent and youth panel, which was really great and really interesting in February, and they spoke about mental health in urban American Indian families. So that was really great. And today we're going to be doing a data share. Before we go into all of the really great content, we're going to cover some housekeeping items. So at this point, being about 2 years into the pandemic, I'm sure a lot of us are familiar with Zoom functions, so we're just going to do a basic overview. If you have a question or a comment, you are free to use the Zoom chat box. So if you click on if you move your mouse around, you will see your Zoom toolbar at the bottom of your screen. There is an icon that says chat. It looks like a text box. So when you click that, you're able to message everybody. There's already been some text that have gone in there, so you're free to use that chat box. There is also our mute and unmute button, which is that microphone there. So please, if you are not speaking, make sure that you're on mute so that we can avoid any distractions and any background noise. And there's also the video component as well, that you can choose to show your video or you can choose to leave that off. Let's see, what else do we have? Another unique thing that we offer with our suicide prevention events is a community support resource person. So because of the nature of suicide and, talking about suicide and having discussions, especially today when we're going to learn about the impact that it's had on our AI tribes, we have to have a community support resource present in case there is somebody that becomes overwhelmed with the information that we're about to share. We do realize that we have many, many survivors of suicide that join these events, and some of the content that we talk about can be activating, and they can, bring up some of those heavy feelings. So if you need somebody to talk to at any point during this presentation, please feel free to reach out to myself. I am the community support resource. If I see a chat, come into the chat box. I will respond to you privately. We won't address publicly. So we'll continue that conversation there if you need someone to talk through those heavy feelings with. So we want to put that out there as an option for all of you, that we are here to help you and we are here to support you while we're in this space. I also want to mention that there will be a survey at the end of the session. So please, please, please take the survey. We're going to add it into the chat box. But it's really important to get your feedback because we value that feedback and we actually use it to help us plan better for future events that we have coming up, because we do have this event every single year. And so your feedback really helps us tailor what kind of topics it is that we present for you all as community members. So without further ado, we'll go ahead and get started. In today's final session of the 2022 Suicide Prevention Convening, Jamie Ritchie from the Intertribal Council of Arizona will share data collected on the impact of suicide in American Indian tribes. So Jamie Ritchie is a public health practice epidemiologist with nearly 20 years of applied public health experiences. She has been in her current role as the Tribal Epidemiology Center Director for almost 10 years with the Intertribal Council of Arizona. In her role, her main focus is to use key skills to enhance public health capacity to serve tribal communities in Arizona, Nevada, and Utah. She also serves as an adjunct instructor at Southern New Hampshire University and has taught program evaluation, public health biology, and social and behavioral health for 3 years. She has served as adjunct faculty with the University of Arizona for over 8 years, and in that role has worked cooperatively on surveillance publications focused on American Indian health, assisted epidemiology students with practical internships towards graduation, and has given seminar course lectures. So I will now pass on to Jamie.
Thank you so much, Kyrene, for that kind introduction. I can go ahead and pull up my slide deck here for everyone. There we go. So today I'd like to cover a little bit about what the data says. And I think that if you've worked with data before for American Indian communities, you'll find that I think it often leaves a lot more questions than answers. So we're going to cover some of that information that I pulled together from public sources today. So I'll give an overview of ITCA, Intertribal Council of Arizona, and the Tribal Epicenter, a little bit of background. We'll talk about some data. We'll talk about ITCA tech, behavioral health programming, and then we'll do some questions and comments. So Intertribal Council of Arizona works to provide American Indian tribes with support services that support tribal sovereignty. That's our main goal, okay? So we have an ITAA side that's an association that lobbies, and then we have our nonprofit side of the house that provides services to tribes similar to Phoenix Indian Center working with the urban population. So we work with the Phoenix service area and the Tucson service area, which looks like this. You can see in orange with Nevada, Utah, and Arizona being the 3 states in which the tribes are located within. Now, you know, look, we've got some tribes that are down south that are also in Mexico. That's not covered here. We don't provide services to Navajo Nation. They have their own tribal epicenter, but they're our sister agency. So we do work with the Navajo Tribal Epicenter really closely. We also work with Indian Health Service. We work with the 3 state health departments. We work with National Indian Health Board. So those are some of our partners. You can see where there's other tribal epicenters housed across the country. So this is very much a national effort. I meet with the other tribal epicenter directors every 2 weeks now via Zoom. mostly to discuss COVID and data access and information to ensure communities have what they need. So I wanted to say a little bit about what epidemiology is. So my doctorate is in epidemiology. So I'm a doctor, but I'm not a medical doctor, and I don't work in behavioral health. I'm not a behavioral health counselor. I'm an epidemiologist. So just to be clear, and give that ethical practice statement, epidemiology is the study of the distribution and determinants of health-related states and events in specific populations. So I'm looking at the population level, not necessarily at the individual level, at trends of risk factors for disease, protective factors for disease, and that's really our main goal. And that can be in a number of different populations. So I worked for the city of Chicago previously as an epidemiologist, and so my population would be the city of Chicago. I worked for the U.S. Army, and I was a contractor, and we worked to provide statistics for behavioral health and self-harm. And our population at that time was U.S. Army active duty troops. Okay, so a lot of places staff people that work with data and information, and your population can shift over time. Our population with Intertribal Council of Arizona are the tribes of Arizona, but also the tribes in the Phoenix, Tucson service area. So tribes in Utah, Nevada, and then some of the communities also are in Mexico, right? So that's an important distinction. And, I also have a master's degree in public health, and I may not use my doctorate every day, but I use my master's in public health every single day. I'm definitely a practice epidemiologist, not a research epidemiologist. So the funding that we receive from Indian Health Service and Centers for Disease Control, it's very, very clear. That's to support communities, tribal public health, and tribal behavioral health centers. It's not to conduct research, okay? In fact, I'm not allowed to conduct research with those funds. I would have to have additional funding that's specifically for research. So, we didn't have the wheel of the 10 essential public health services when I was in school, but this wheel came out. So I think this is important too, because it shows how data fits into the bigger picture. And really, when you've probably heard discussions surrounding equity at this point, right? This model of health equity, you've probably heard that in terms of COVID quite a bit. So, we want to be able to assess and monitor population health, and that's really what the data is for. And so that data can be collected numbers, it can be stories, it can be qualitative information from focus groups, key informants. Particularly when you're dealing with small numbers, it's better to do qualitative data when you're working with focus groups and directly with people and key informants. The information is going to be better. So I don't have any of that data right now to share with you in relation to suicide, but just keep that in the back of your minds that, when you're dealing with small numbers, the information is really actually more powerful. When you get into the quantitative information, and I'll talk a little bit about what that means, it kind of, the story gets lost. It's hard to work with. So, when I was working with US Army data, that data can get really small really quick. And when we're working with our tribal communities, that data can get really small really quick too, right? So it's hard to make inferences or population level types of conclusions when you have small numbers of things, okay? It can be washed out, but it doesn't mean that it isn't important, right? So that's key. So this wheel kind of covers, how data fits in and how we're building good programs and then evaluating them to make sure that we're able to create appropriate policy and appropriate programming to address these concerns. Because the data on its own really is just that. You want to have data that's actionable at the end of the day. Otherwise, spending the time and effort to collect it really isn't worth it, right? You know, you have to make sure it's actionable. So you may have heard some rumblings about social determinants of health too. And it's basically just another framework. So, you know, the sciences like to have all of these frameworks on how we're going to, you know, do things. And social determinants of health is one of the most recent ones. So, you know, we've got the education, access, and quality, healthcare access and quality, neighborhood and built environment, social relationships, economic stability. You know, none of this is a big surprise to tribal communities. You know, they have their own models and things too that I'm not going to discuss here because that's private cultural information. But if you do go out into literature, you can find some of those things are published. And so our tribal communities have these models too, okay? They have their own health departments. They have their own systems of doing things. This is just a Western model of doing things that I can share with you today. But the tribal models really, you know, there's different components to it because that's what's going to fit their community, right? Okay. Now this is really horrible. Sorry about all the text. You can have the slides later if you want. But this is another model, Principles Guiding Population Health Framework for Behavioral Health. And this is through the American Psychological Association. Again, I do not work in sociology or psychology. I'm an epidemiologist, but this is a framework that can be used along with data, right? Because you see use data and best available science to inform policies, programs, and resources as bullet number one. Everybody wants everything to be data driven, which, you know, even as an epidemiologist, I love data, but I have some concerns about that. Okay, and we're going to talk about some of those concerns as we move through the presentation. All right, so here was another model that I pulled up from the literature just recently, and this relates to COVID and how the COVID pandemic is impacting psychiatry from a Western standpoint, you know, working with depression, anxiety, PTSD, grief, acute stress reaction, these sorts of things, and how this is leading to different they call it psychosocial risk in this model, okay? And that could be called different things in different areas of practice. Now, I don't have data on all of these things, and I don't think most people do. So when we see a model like this, or even our social determinants of health model, I think, you know, it's a great wish, but a lot of those things I can't even measure for the general population, let alone for smaller populations as well. So, you know, those are some limitations. We can build these models, but if we can't measure these things, then the model is just that, it just reverts back to theory rather than practice. So now I'm going to talk about some data. And, you know, as an epidemiologist, one of the first things we always want to do is make sure what we're seeing is real. So a lot of times we start off and when we look at it, we're not like, wow, this is the greatest thing ever. We're like, this isn't true. We start off thinking this isn't right, you know, and then we start looking at things and trying to figure out whether or not it's true, okay? So, you know, I'm coming at that using that lens. We do know that we have some self-harm issues within our communities, you know, across all 3 states. We know that, okay? There's no question about that, but I'm not necessarily sure the data does a great job with capturing that information, okay? And I'm going to cover a little bit about what I mean about that in the next few slides. So today I wanted to cover the mathematical measures that I'm going to talk about, just to make sure we're on the same page. So I'm going to talk about numbers and counts, and that's like 10 of something or 5 of something. There's nothing, you know, that's just how it is, okay? Just counts and numbers. So when I say counts and numbers, that's what I mean. When I say percentage or prevalence, it's like based on 100%, okay? That's your scale is 0% to 100%. 100 is going to be your denominator, okay? So it's like pieces of a pie, right? So if I have a pie you know, I can have a third of a piece of pie or a quarter of a piece of pie, or I can have half of the pie at 50%, right? So that's what I mean when I'm talking about percentages or prevalence. Now, rates, this is when we start getting a little bit more theoretical. This is when stuff starts to usually break down. And you'll hear in the media a lot of times, well, the rate of this or the rate of that, and they're not even talking about a rate. They're usually talking about a percentage, okay? So, and it drives me nuts. It's one thing that'll really drive me nuts. But really, a rate can go on forever. It can be to like infinity, okay? So you can have infinity of something with this. You're not really bound. But you are bound by time. So, you know, I'll say usually, you know, a year, it'll be like a year time frame is what we like to look at. For some things like COVID, a year is way too long, right? We want to look over days or weeks, right? So when you look on ADHS's website, if you've been there for COVID and you look at their case counts of COVID by day, that's counts, that's the first one. And then they're building this chart so you can see how the disease is increasing. But then you can't compare things if you're looking at counts. So we can't compare the state of Arizona to say the state of Utah. We would have to have a rate to make that data and information comparable, okay? So people compare proportions all the time or percentages all the time too. They'll say, you know, 25% of this group compared to 25% of this group has X disease. That's not correct to do, but you'll pull like federal reports and they'll do it all the time, okay? So you don't want to compare percentages, you want to compare rates, but rates are trickier to calculate. You have to have a denominator. So if I'm going to do a rate for a tribal population, what I have to know is how many people are in that denominator. So I know the tribal folks here know exactly what the issue with that is. Where am I going to get the denominator, right? Are they going to give me their tribal enrollment list and their counts? No. So I have to go to census data and get that as a denominator, right? And how good is that? Whoa, okay. So now we're introducing error into our denominator right there, right? By using the census data for our denominator that defines the count of our population, right? And then for whatever, you know, risk factor or protective factor that we're going to talk about, that's our numerator. So that number goes on top. And that number over that specific period of time is going to be divided into the whole. And so if we have error in our numerator too, because maybe we don't have a tribal surveillance system, maybe a lot of people don't tell us about certain things that are going on with them, right? We know that's true. So we may not have a very accurate numerator, and we may also not have a very accurate denominator, right? So even if we do have a rate, we have a rate constructed, it just might not be telling us the truth, okay? But it's as close as we can get. All right. So with that background, so now here we have mortality rates, or more simply death rates per 100,000 population. The per 100,000 is just a multiplier. I can use 10,000. I can use, you know, 100. It doesn't matter. It's just a multiplier to scale out the data to make it more comparable. And then it's by cause. And I looked at this for American Indians in Arizona. So this is a full state of Arizona. And I covered the time frame from 2005 to 2019. I didn't pick this for any specific reason, that time frame, just that it fit on the slide, really, you know. That's how I could chart things out. So, you know, when we're talking about our self-harm statistics, I want to point to the point here. It's not that it isn't important, but it's our lowest one right here, okay? Our highest one is the cardiovascular disease, okay? Right. The next highest one, here we've got cancer for a little bit, and then the purple one, I think that's unintentional injury, but I apologize, I can't see it. My toolbar is in the way. Yes, it's unintentional injury. So car accidents, falls, those sorts of things, is this purple one here, right? And then diabetes is down here, right? So diabetes is important for our tribal communities and for American Indian communities in Arizona too, right? And then there's suicide. So just to give you how this is comparable to other, issues that we have in the state, right? That's why I'm presenting this information. So now for self-harm rates by age group, and I particularly wanted to look at youth because we know from the national data that our American Indian youth are experiencing some issues. But I wanted to look at everybody because this is the data and information I could find. I couldn't find this broken out for American Indians by age, okay, in the state data. So this is 2014 to 2018, all youth in the state of Arizona. So, we've got the 20 to 24-year-old age group, 15 to 19 year, and then 15-year age groups. Now, you may say that the 20 to 24-year group is most at risk, but I don't know if that's true. And that's because I don't know how these rates compare to each other because it's missing something. It's missing something called a confidence interval. And what a confidence interval tells me is how comparable this information is. So if I was to put a confidence interval around this rate right here, it may stretch all the way down to here. Or it could be really tight and just be right here. If it stretches all the way down to here, what that's telling me is these are not statistically different. So I don't have that information, even for the entire population for all of our youth in Arizona. Okay, it just wasn't in the report. Like I said, I'm providing public information today. So, that's a big concern to me because I don't know if our age groups have differences, right? So when we're providing tailored programs and services for our youth, when I look at this data, I can't use it and make it actionable to say which group of, youth is most at risk. Okay, so at this point, when I see a chart like this, and I know the national youth statistics, I'm just going to focus on 15 to 24. I'm not going to break it out and tailor a program, right? Because I can't. All right, so now we're going to talk about the sad stuff. So CDC provided a lot of risk factors, and I'm not going to read all of these. We know what these are, right? We know. Our friends have had these, our families have had these, we may have even had these, right? So these are the things that, can lead to self-harm. There's other things too, but these are the main ones that CDC has determined. Now I don't have really, too much data on this, you'll see, when we're moving forward, and there's some reasons why, and I'm going to share with you some reasons why too, even at a state level, why we might not have as good of information on this as we may want to. Now look, just because someone has these things though, it's not a self-fulfilling prophecy, right? You can be totally fine too. Okay, so it's not really clear at what point that risk profile becomes I guess detrimental, right? So just because these things are present doesn't mean they will cause a problem either. So we don't want to stigmatize people and say, oh well, that person had family problems, so we really need to watch them. Don't know, right? And we should just treat everybody with loving care. Okay, so I pulled this one out of the public report or out of our public report that's on our website. You can see the link down there. Our Tribal Epicenter does a big lift for community health profiles every 5 years. So we have our regional data report that's up online. And from this, we have a mix of Indian Health Service data, Arizona hospital discharge data, Nevada hospital discharge data, and Utah hospital discharge data. So these are the number of self-harm inpatient hospital visits among American Indians that were discharged from the hospital for self-harm visits. So, you know, you can see we've had some visits, right? You know, for self-harm. So, you know, we want all of those to be zero. Sorry, y'all, I'm having trouble with my slides advancing and doing things I don't want them to do. So we want these to be zero, right? We want zero suicide, right? That's what we want. That's a model that we want. And right now, when we're looking at this data, we've got a ways to go. Okay, so, and these are just counts. Remember, these are the easiest ones, you know, and it's from 2015 to 2019. And if you're interested in that report, I have the link at the bottom, and you're welcome to email me and my team. My team did a wonderful job working on this during the pandemic to get this data out for everybody. So now, you know, I'm going to talk about the Youth Risk Behavior Survey in Arizona. I got this data off the CDC website. So now remember, Youth Risk Behavior Survey may or may not be in tribal schools. Okay, so if I'm working with the tribal population, this data is going to be limited. And even if they are working with the tribe to collect this data, the tribe may not add that data to this information. Okay, they may choose to leave it out. All right, so that's kind of barrier number 2, right, to this information. And when I pulled this data up, it was really weird because it said less than 100. So they had in the youth risk behavior data for Arizona, when I read it from CDC's website, where you can pull up and make your own charts and graphs and whatnot, they had less than 100 American Indian students in the data. Okay, less than 100, and I don't know the exact number. I just know it's less than 100. So then the next thing that I had trouble with was when I looked at the data and I pulled up the table, it just had numbers on there, and I didn't know if those numbers were percentages, rates, counts. Remember we went over that slide? I didn't know what it was. It just gave a number. And I was like, that's really weird. So then I pulled down the Excel file, you know, I downloaded the file, and then in the file, it said that they were counts. So I'm like, okay, I'm working with counts. So here, you know, for the youth, it says resulted in injury, poisoning, or overdose that had to be treated by a doctor or nurse in 2019, 34 and 30, right? And, you know, so to me, this doesn't really give me a very complete picture about what's happening with our American Indian high school students, really at all. Okay, I wouldn't say that this informs, you know, I would say this created a lot of confusion even for me. And, you know, I've worked with data a long time. Thank you for considering me an expert. I just had a lot of experience in this, and I was very confused as to what it was telling me. Okay, what it does tell me is that I want more information as to what's going on here. And I also, you know, talked with folks at ADHS, and I showed them the slide deck, and I'm like, what do you think about this? And they made a little comments, you know, this or that, but at the end of the day, I can't really say a whole lot about what's happening with our youth from this slide, okay? But what I can tell you is the good news is that more than 90% of people, any people who attempt and survive, never go on to die by self-harm. Okay, so there's just a CDC fact, okay, and that's for everybody. It's for all populations, okay, so that's good news, right? We want to prevent it from happening to begin with, but you know, we're pretty close to 100% on this one. We've almost got the full pie not dying from self-harm, right? You know, that's pretty good. All right. So now occupation is also a risk factor for self-harm. You know, every time the occupation changes, you'll hear it. You know, at one time it was dentists had some of the highest rates for self-harm, okay? I don't know why, that was just what it was at the time. Now we know that veterans may have, higher rates of self-harm per 100,000 in Arizona for the year 2018. Again, this was by age that we looked at this. And, we see with the veteran status being in red and the non-veteran status being in blue. So not terribly different. Again, don't have confidence intervals, so I can't tell you if these are statistically different or not. They could actually be representing the same thing. I don't know. But that's the information that we have. Now, when things really got interesting to me, and I asked some pointed questions for our colleagues at Arizona Department of Public Health Services, when we're looking at our self-harm rates by race and ethnicity and veteran status in Arizona, you can see for American Indians and Alaska Natives, non-veterans are actually having higher rates than veterans. So now I don't know, again, if these rates are unstable and the rate for these two groups, regardless of occupation, is around the same, right? I don't know, because we don't have the confidence intervals, but it is suggesting that veteran status may be protected. And, when we were working for the US Army and working on their data, look, more men and women serving the country never had an issue than those that did with self-harm, right? So I think sometimes the veterans population may get stigmatized too, all right? To say, oh, they're going to have all these mental health challenges because of their service. That may or may not be true. And so I'll just point to the non-Hispanic white group. We still see that, that group has the highest rates, okay? It's usually non-Hispanic whites, American Indians, Alaska Natives, and then, Black African Americans, and then Asian Pacific Islander and Hispanic communities tend to have lower rates. Now, they still have, they're not zero, right? So it still deserves attention within those communities, but typically, non-Hispanic white and American Indian, Alaska Native communities have the highest rates of self-harm. What's interesting is, those two groups, by counts, it's the most people in the Army are white, but one of the highest rates for enrollment into the armed services are American Indians. So, American Indians join the armed services quite frequently and serve the United States government. So, they're definitely of service. So when we see this, we see veteran, non-veteran, it looks like it might be different. It may or may not be, but I did find that to be something that's a little bit different than other data I've seen in the past. I don't get surprised too often. That is surprised. So, from our community health profile, again, we have Indian Health Service visits, Arizona hospital discharge visits, Nevada hospital discharge visits, Utah hospital discharge visits. So this is the whole state. And these are the number of mental health inpatient hospital visits among all American Indians in Indian Health Service and, the Indian Health Service area, and the hospitals in hospital discharge in those states. So you can see again, we've got folks going in for treatment for mental health concerns. I don't think that's a bad thing. I think that this is a good thing. It's preventative if folks are going in and getting care and asking for support, and these things are getting recognized before we get to self-harm. This is good. So I know that mental health often is looked at as a quote unquote risk factor, but look, I wouldn't have data on these folks if they weren't seeking out services in some way, shape, or form. Okay. So seeking out care is not bad. It's good, but it is labeled as a risk factor in a traditional sense. Okay. But seeking help is good. Now, another caveat to this data is this isn't one individual person. Like one person could go 20 times in here, right? So I could have, only, 1,000 people doing all these visits, or I could have 95,000 people doing these visits. I don't know. So we do have our data protected in that way. So, you don't see just, it's not at an individual level. Again, remember, I'm a population scientist, right? Not working on individual people, but looking at the community as a whole. So we're concerned about number of visits, right? And that's good for hospital systems to know how many visits they've had in the past, because then they can probably anticipate about that many or maybe a little bit more in the future too. So this type of information is good for planning purposes in that sense. So a little bit of work, surveillance work that I worked on with Dr. Cunningham, Dr. Tisha Solomon, and Dr. Maya on mental health. We looked at findings that suggest an underdiagnosis of mental illness among Native Americans. I like to use the word American Indian, but I didn't get that. I had to use Native American. I didn't get my way on American Indian. That are hospitalized with alcohol and nicotine disorders. Okay, so like you had an encounter with the hospital system, and then it was either and then was there a mental health diagnosis that corresponded with the alcohol or nicotine disorder? Okay, did you get this post-secondary diagnosis so that way you could get support, right? So when we looked at the national data, there's a similar prevalence, of mental health disorders between non-Hispanic whites and non-Hispanic American Indians. And I'm going to make that distinction, non-Hispanic American Indians, because in Arizona, we have a lot of folks that are Hispanic and Indian, right? So, there's a limitation to this information, okay, that we don't have Hispanic data. And it's something that drives me nuts. And but it's not something that I always have. In fact, in these hospital discharge data sets, I'm lucky to get race. So that kind of drives me nuts too, because then it's difficult to make targeted interventions when we don't have that information. But it's an administrative data set. It's not the purposes are for payer, right? It's to collect money. It's not necessarily the purpose to do population health, but in the absence of, really strong population data, you saw YRBS, right? That's not that strong right now. I'm not feeling strong about that. We use this data too. So ultimately what we found is, our Native American counterparts were not getting diagnosed with, a mental illness diagnosis as frequently as non-Hispanic whites. So it maybe they didn't have one, but it could also be a differential in care too, right? And if we're seeing similar national prevalence, we would expect to see a similar prevalence of diagnosis then too, right? I mean, those two should track, and they're just not tracking. So that paper is out in the literature too, and that's important because if someone's having an encounter with a hospital, for something that might, indicate a mental health diagnosis, that, they deserve to be diagnosed and treated just the same, yeah? So, but that's not necessarily what we're seeing with that information. So that's basically what that data analysis showed. Okay. So, and then we've all heard about social isolation with COVID. About half of the US adults report always feeling alone or left out. The entire population of adults, about half of them feel alone or left out. That's a huge problem. That's huge. 1 in 5 people in the US reported that they don't feel close to people, or that they have anyone that they feel they can talk to. That's bad. You have to have friends and family. And then the Gen Z group, born from 97 to 2012, they were reporting to be the most loneliness. They have the most loneliness. So, we know that loneliness also, impacts you the same way cigarette smoking does, the same way, Our diet impacts us, our social interactions are really important. And, as a country, we're not doing a great job. Now, I will say with tribal communities, we know that, we have multi-generational households a lot of times, not always, but a lot of times. And, there was an issue, quote unquote, with COVID because of the spread of the infectious disease. But I wonder if it wasn't a protective factor for loneliness, which is another disease that can also cause problems, right? So, I would say that there might be something that's extremely protective in our communities, despite, a potential disease transmission issue. So that was disturbing when I saw that information. I didn't know that. So again, I've got the YRBS data, which, I've got some concerns about. And when we're looking at, females and males, it doesn't include the two spirit community, which is again another group that is underrepresented in data and information. I do get phone calls about the 2S group. I don't have any data. There's a paper that is going to be coming out in our public health reports journal supplement that the tribal epicenters are working on that does have some 2S plus data in it, finally. And there's a little bit out in the literature, but just not enough. So here we see American Indian high school students that felt sad or hopeless. And this is awful. It should be zero. Kids shouldn't be feeling sad or hopeless in high school, right? So the fact that this isn't zero to me means that regardless of whether or not this count data is good or not, we do need to be addressing it because children in high school shouldn't be feeling sad or hopeless, right? They should have the most hope they ever do. And, this one experienced sexual violence. This was really hard too. It's like, wow, so this is what's happening with our kids. Now, again, I can't really, tell you the magnitude of the problem, but the fact that it isn't zero, it means it's an issue. Didn't go to school because they felt unsafe at the school. Now, there wasn't any clarifying as to why they felt unsafe. I don't know if they felt unsafe from the other students, or they felt unsafe because of the teacher, or they felt unsafe because of some other factor. I don't know why, but overall, this should be zero, and it's not. And then we've got kids bringing a weapon. Now, it didn't say what kind of weapon, but they felt they needed a weapon at their school, right? Or needed a weapon at some point, right? They're carrying this weapon. Why? Why does the child need a weapon? No child should need a weapon, right? And then the sexual violence piece, which was concerning too, again, not zero. And then when we're looking at the electronic age, and we have students that are, using Zoom for their classroom and things too, we would think that that could be more heavily monitored, right? Because you usually have a parent in the room, or you have a guardian in the room, or you have a teacher in the room. You would think with electronic, there would be a less opportunity to bully, but the kids, it's not zero. There was bullying of the kids. So that's the sad part, right? So there's also some really good things too that I wanted to talk about from some of the data sources, again, that are public, that can serve as protective factors when we're looking at our social determinants of health model. So again, CDC lists out protective factors for self-harm, coping, problem-solving skills. I didn't really find any data on that was really seriously measurable. Of course, cultural and religious beliefs, we know that our programming focused around these two pieces is particularly powerful. Connection to family, friends, and community support, and relationships with care providers. And then the availability of healthcare. And then, of course, limiting any, means of things that could cause harm, okay, in the household. So we've done some harm reduction. We bought some elder safes so they can lock up their medications as part of our, opioid programming. That was one of the things that we did for some of our communities. So there's some different, strategies that can be used around that to prevent self-harm too in the household. So, we see all this gloom and doom in the news, and we hear all these things about American Indian communities. and then when we start looking at things, I've got Arizona Behavioral Risk Factor Surveillance Survey data up. Now, again, this is really limited. I only had data back to 2016, okay? So, I don't have more recent information. There's a number of reasons for that. This is also based on a very small sample of American Indians. So I know it's less than 100 American Indians in this sample, okay? I know that because I've looked at the data before and it's small, right? But when you're stratifying it out with the rest of the population, it does come up to that proportion. But you can't look at individual, pieces. It has to be representative population. So one of the things that Office of Minority Health intends to fund, and Arizona is on the list, is an oversample of American Indians in the state, which is good because then that data will improve and it'll get us better information. Having said that, I mean, over 60% of American Indians reporting into this survey, they said they're in good or excellent health. Good or excellent. Not fair or poor, good or excellent. Okay, so, we're hearing these things, but we're not getting the other side of the story, okay? We hear about how, poverty causes all these problems. We hear, American Indians don't have as much and this and that. We hear about that in the news. We hear about that. This is the messaging, right? 93% of American Indians are not living in poverty in Arizona in 2016 that answered this survey. 93% is what the state is estimated. That's almost everybody not living in poverty. That's pretty fantastic. Now, look, that's not to say that there are problems, okay? That's not to say that at all. But I mean, this is a pretty good proportion, And granted, just not being in poverty doesn't mean that you're doing okay either, right? Like it can still be extremely stressful just because you're not meeting this federal threshold. It doesn't mean that everything is now great, and you're, have everything you need. But we know that, the dire situation is focused on approximately 7%, Okay, and then the drinking. Okay, I'm from Irish descent, so we get the drinking thing too. Okay, all the Irish people are drinking all the time. We're not, and neither are the American Indians. 93% of American Indians estimated from 2016 Arizona Purpose survey were not drinking at all, not even once. Okay, or they were moderately drinking alcohol. Okay. And so, this perception, of certain communities, of, binge drinking and doing these things, it's just not accurate from what our data is showing. This is one example. Dr. Cunningham and Dr. Solomon, who I've worked with in the past, they put out another paper looking at youth binge drinking, and American Indian students were just not binge drinking at the same proportions as their white counterparts either. Okay, so it's just an incorrect perception. And that's not to say that there aren't some issues, right? But when we're thinking about 93% say none or moderate alcohol use, that's responsible alcohol use. Okay, the perception is incorrect. This general perception from media and papers and past research, right? It's just, this data doesn't support that. The other thing is the percent of American Indians reported being physically active. Now, this is really good. And the reason why I wanted to include physically active, we've got 79% of folks being physically active. We know this impacts your mental health. We know it does. It reduces your anxiety, it reduces depression, it reduces all of these negative, factors. It reduces, your A1C, it can reduce your blood pressure. Even just going out for a walk 30, 40 minutes a day really can do a lot of good. And here we're seeing you've got 79% of folks that were answering the survey data in 2016 being physically active. So that's a good thing, right? So then, there's also a perception about diabetes in a lot of communities. So we've got 80% of American Indians that do not have diabetes. Now, that's not to say that diabetes is not an issue. That's not to say we shouldn't focus on it, but not all American Indians have diabetes. The reason why this is important to me is because we know that diabetes is also linked with depression, isolation, the inability to exercise. There's a lot of things that go along with this hormonal disease that, can impact mental health. But we've got 80% of folks no diabetes. I mean, that's good. We've got 20% with, but that can be managed, right? So I did want to include this slide too, because I think there's a common misperception about our American Indian communities with this health conditions. So I want to talk a little bit about ITCA Tech and what we're doing in the area of behavioral health. Again, I'm not seeing patients. I don't work at the individual level, but we do provide some other support. So we received some funding from the Centers for Disease Control and Prevention to look at suicide, intimate partner violence, and adverse childhood experiences. So really what we did with this is we provided subcontracts to our tribal communities, small pieces of funding to work on projects during COVID with us. So that's one of the things that we did. We also worked with Bluestone Strategy Group and constructed an after-action toolkit specifically on behavioral health, provided a workshop in the toolkit for our behavioral health providers. And then we're also working on a risk communication toolkit with Great Lakes Tribal Chairman's Board and 7 Directions, which I'm excited to see how that risk communication toolkit will all come together at the end. We've got that planned for launch, I believe, at the end of July. So I'm excited to see how that'll come out. So those are some of the ways that we support our tribal health departments and tribal behavioral health centers during this time. We also received funding through Indian Health Service to be a technical assistance provider for suicide and substance abuse programming, domestic violence programming, and forensics healthcare. So tribal applications, I believe, are in review right now. I'm pending to find out who the awardees will be for Indian Health Service, so we can work with our tribal communities to assist them in areas that they need. Usually, we'll analyze data, we'll provide, we'll assist with survey construction, we'll do some different things of that nature. I forgot to mention this and I wanted to. So just backing up to the behavioral health programming with the coronavirus 2019, one of the things that we did with our tribal communities was we're working with Johns Hopkins University to provide technical assistance as well for our communities to work on planning their own surveillance systems within their communities for suicide, ACEs, and IPV. So I'm not set up to be a data repository. That isn't really what I do. What I like to do is provide support to communities, particularly tribes and sovereign governments, to collect their own data and information and analyze their own data and information so they can use it. At the end of the day, they're the ones that need the information. It's their community, it's their population. They should have it, control it, and use it. So that's how we operate at ITCA. So one of the things we did do is, work on this partnership with JHU. So I'm glad that that's in place. And Dr. Quick has been wonderful. And I think our communities have really liked working with her. So that was another piece of this project that I didn't put on the slide. I forgot to mention it. And then of course, the National Suicide Prevention Lifeline, it's always important to have a place to talk. They may not be as culturally competent as we would like them to be at all times, but it is a resource. And of course, for all of us, what we can do every day is, be kind and wonderful to each other, because I can pass out telephone numbers all day, but if I'm not kind and loving to the people around me, it really doesn't matter, does it? With that said, the best thing we can do is to just be there and treat people well. And, even doing that, it may not work 100%, but, it's one of those things. To prevent self-harm, it can be very, very important. And you just never know what your impact is on someone, especially your colleagues and friends and family. So that's what I prepared for today. I'm happy to answer any questions, comments, anything anybody would like to know. I'm happy to open it up.
Yeah, and that was a lot of great information. Thank you so much, Jamie, for sharing that with us today. Before we go into questions and comments, we're actually going to take a short break. And during this break, we're going to start with a little raffle. So we have some items that we want to raffle off to one of our participants. So we're going to start with that. I'm going to pass to Amanda for a bit, and then we'll go into a short 5-minute break. So we will be back to address Q&A. So if you do have a question or a comment, or you want to have some discussion with Jamie, please stay in the Zoom room. We still have more to offer, but I'll go ahead and pass it to Amanda for our raffle.
There we go. Okay, you guys can see our break raffle time screen. So I'm going to bring up my wheel of names here. And so I'm going to shuffle these once I get this shared over here.